Whether it's an X-ray, MRI, CT scan, or ultrasound, medical imaging helps answer some of healthcare's biggest questions.
Welcome to What Brings You In Today, a podcast from SGMC Health.
I'm Kara Hope Rockwell.
And I'm Erica Bennett. And today I'm here with Mark Hodges, who's the director of our imaging services, and Dei West, who's our MRI Safety Officer at SGMC Health. So what brings y'all in today?
To promote all things imaging.
All right, imaging plays a big role within a health system. Yeah. Often not really thought about, but definitely something that's ordered all the time. So,
yes.
Mark, you want to kick us off and tell us maybe just an overview of the role that imaging plays at SGMC Health?
You know, when you hear the word imaging, you think of X-ray. You think of when you have a fracture, a broken bone, you come to the hospital, you're going to get an X-ray. And that's where, that's the starting point for us. That's the entry into medical imaging. There's so much more to it than just that modality. There's CT, there's MR, there's nuclear medicine, PET, ultrasound, interventional radiography, bone D, mammo. So we have all these different modalities that were at one time considered X-ray or radiology. Mm-hmm. So the newer term for it that's come about is medical imaging to encompass all of these modalities, and not just consider it just X-ray.
Yeah.
So, yeah.
Before we dive too deep into the details, let's introduce yourself. Say, how did you get into imaging? What's your career path been?
Oh, wow.
Where do you start?
Yeah. So I was dating my wife at the time. We were dating, and I was going to VSU. She was going to Wiregrass, and she said, we need to swing by the school. I've got to talk to my advisor. So she was in there talking to the advisor. I was out pacing the hallway, just going back and forth. And her advisor said, "Who's that guy out in the hallway?" And she said, "That's my boyfriend." And he's like, "Pull him in. I need to talk to him." So he was trying to recruit me into Wiregrass. It was Valtech at the time, and I said, "No, I'm already in school at VSU." And honestly, I was headed into nursing. Mm-hmm. I just finished up my core, and he challenged me. He said, "Go up to the program, go up to the department, and just look at it and see." So. He connected me with one of the radiologists. I come up here and stood there behind the radiologist for an hour or so, seeing the images, seeing what they were doing, and I was hooked at that point. Instead of treating a disease, we were able to see it. Mm-hmm. We were seeing what was going on, inside the body. Fascinated me. The next week, I was in. So I started working in the field probably my second quarter within the program. I was in a unique situation with Smith Northview, come in and help them transition to the new hospital. And about the same time is when we started accepting students from Wiregrass, and it just went from there.
That's crazy. What a crazy story.
Yep.
How about you, Dee?
I started at Smith Northview when I was 16 years old.
Oh my goodness.
It was the first summer that they came to Valdosta. So I started at the switchboard, just answering the phones on the weekends, and it was really great because I got to see all the different aspects of healthcare. I knew that was something that I was interested in, and so just being able to see the different parts of like what nursing and the ER and radiology, and so I worked up and through high school once I did switchboard, then I went into registration, worked on the weekends and doing that. And I just saw that radiology was something that fit me and my personality. It was a quick turnover. The people were, fun and energetic, and you weren't stuck in one spot all day long. And so it was constant turnover, and it just seemed like a good group of people to work with. Mm-hmm. So I've been there ever since.
Yeah, it's so interesting, the dynamic that what you were mentioning, radiology, you get most of the time is probably, you get outpatient or inpatient, mm-hmm. but, you have people that are a lot of times relatively healthy that are going in there and checking things out versus like someone that may be in a hospitalized. Right. I mean, I know you have both worlds, but it is interesting in healthcare. You can kind of make it what you want it to be. Like
exactly.
Yeah.
So that's pretty cool. And with the radiology, how, we think about labs and stuff. So I always like to think like labs in the blood work, diagnosis something, but then also the imaging. You got to have that to kind of complement.
Yeah, we have lab as the chemical component of diagnosing, and then we have, the imaging side, which is the visual aspect of it. And again, there's so many modalities that can confirm. If there's a negative finding in one modality, that doesn't mean that's it. There's still suspicion based off of the lab work, based off the physical assessment by the physician. So we may, or they, the physician, may order a different modality to see. And very often is when pathology will be found in that other modality.
So we did an interview with radiation oncologist, Dr. Adedoan, before this. And so just the fascination with how we can even have technology that does what it does. Like the machines, the imaging machines, like how they're able to, how they even work in general is just like fascinating. And then you learn all about that and you learn how to like see what is different in there and work with the radiologist for that. So I just think it's a very cool.
There's a different world between the operator and the engineer who's working on this equipment. And I tell you, MRI is one of those that will, we need
You have to have a physics brain for sure.
We need a subject matter expert like Dee and the other MRI technologists to be able to be that liaison between me and the engineer so that we can communicate back and forth. Because if not, a lot of it is just over your head. And again, you look at the components of how an imaging is produced through MRI, it's mind-boggling. It's just mind-boggling.
Yeah.
And it's completely separate from how radiation works and how an X-ray or CT is, developed. And I tell everybody that starts training, I said, you take everything you learned in X-ray, you throw it away. Throw all of that away, and we're going to start fresh. I'm going to teach you a whole new set of physics.
Yeah. So talk a little bit about your role, because I understand that it's a newer role here at the health system.
Correct. So with some of the new accreditation organizations, they have started really looking and diving deep into patient safety and making sure that not just patients are safe, the employees, the facilities, and everything runs smoothly, and that we're taking care of everyone. And so ACR has created these positions. There's MRSO, which is what I am, is the MRI Safety Officer. There's a MRSC, which is a physicist or physics expert, and then we have an MD, which would be our radiologist, would be our primary go-to, who's the most knowledgeable about implants and scanning and things of that nature. But we just kind of make sure that we're taking care of our patients and doing it the safest way possible. If there's an implant that 10 years ago that we couldn't scan, now we have so much more information about it, and we can scan things and we can do it safely. And that's kind of the role of trying to figure that out and where and how. So.
Talk a little bit about MRI and what makes it kind of unique and safety-wise.
Yeah.
Well, it is a big magnet, and one of the things that people forget is that they say, oh, well, I don't hear it, so it's off, right? It's not. That magnet is always on. It is always pulling at the same amount of strength, no matter what. And it just uses a completely different set of physics to produce its image, and, it just is its own little world.
Yeah. So like you have to make sure you're checking everybody. They don't have any
my badge is different from everybody else. Like I don't wear anything on here that could be pulled. We're working on getting, staff and throughout the facility screened so that we know without a shadow of a doubt if they're responding to a code or anything like that they are safe to come in. Just because not only can a device or a crash cart or something like that be pulled in, but if I have an employee that has a pacemaker or defibrillator or something like that, it could harm them as well if they were coming in to help. So we're just trying to make sure
that it's that powerful.
Yes.
Yeah, you read these articles. One of the last ones I read, I want to say it was in South America. One of the law enforcement officers was escorting a prisoner into the magnet room. It pulled his weapon out of the holster. It took a come along, which is a farm tool that you would use to move heavy equipment onto trailers. It took a come along to pull the pistol off of the magnet.
Yes.
So it's very, very strong.
Yeah.
We've been very fortunate not to have an event like that. There was one where, and this is where the role of Dei comes in. It's very important in implementing better screening processes, because we had one patient come in with dementia, and as we're going through the screening process, they forgot they had a wristband on, and it was a weighted wristband that had something to do with the nerve issues that he was having in his arm. Anyway, the staff got him into the room, and the minute they sat him on the table, it pulled it and got into the magnet. Well, we were in there trying to pull this weighted bracelet off, and it began to tear. And what we were seeing was thousands of little weighted BBs in this
Bracelet?
in this wristband. So I called the engineer, and he was like, "Mark, stop right now. Like, I'm on my way. Like, this could be a huge problem." So he came in, and we sat there, put our heads together. We had to take a pillowcase and slide in between the weighted band and the magnet, and it took both of us pulling on this to pull this, half-pound weighted wristband off.
Yeah.
Had we ripped the fabric on it, those BBs would have been in everywhere.
Yeah.
Everywhere. And that has happened in one of the areas, close to us. That very thing happened, and that magnet was shut down for 3 weeks because they were cleaning out these BBs from this unit.
Oh my goodness.
There is a way to ramp it down, and there's an emergency button. It's a very expensive button to push. Very expensive.
Yeah, so that's another component of imaging is these machines that you're using are not cheap. They are very expensive, require a lot of training. I mean, it's not like what the layperson might think. You just put it in and mash a button and here you go,
back there.
taking a picture. And you have to learn all of that, all the ins and outs of every single machine. And
just recently, 2-3 years ago, when we went to our new machines throughout the organization, and I'd scanned on the same scanner for 14 years. That's all I ever knew. I could do it in my sleep, basically. It was all muscle memory. And so when we got these new machines, we were all super excited about it. But it was literally like learning a different language, the way that technology had advanced so much in these machines. And it took, all of us really having to dedicate some time to it to perfect it and get back to where we were with our old stuff.
Yeah.
But it's come so far.
yeah, it's kind of like a pain in the beginning because you're having to work on a new system that you don't understand, but then you can see the benefits once you get used to it.
Yeah.
Can you talk about some of those advancements in technology that you've seen over your careers?
It's amazing.
It is.
When we came in, or when I came in, and I can almost remember Dei as a student. We still had a dark room, I believe, and
We weren't dark room. It was still there, but we weren't using it.
Okay, so when I came in, we had a dark room. We were, film through the processor, waiting 90 seconds for it to drop. You're there praying, "Oh Lord, please let me have this image," because the doctor's waiting for it. So, all that's gone. We went to plates, and now it's digital.
Yep.
So the minute you make an exposure, that 90 seconds is gone. It images up immediately. We can make manipulations there on the screen to improve the image quality. MRI, for an example, 5 years ago, a lot of their protocols were 60 to 90 minutes. Bringing in the newer equipment has reduced the scan time on that. In conjunction, we worked on our protocols. We cleaned those up to reduce it even more. And then we added a software component called Boost on this. So we went, on some of our exams, we went from 60-minute scan times down to, 17 minutes?
Wow.
That we can do. So let's just say 5 years ago, we were averaging about 550 MRIs per month on 4 scanners. Now we're about 1,100 plus per month on 3 scanners.
Yeah.
Wow.
On 3. Just because of the technology and bringing up our protocols.
And the patients are so thankful.
I was about to say, it's so much better for the patient.
Like, we have headphones. They can listen to music now. And it's instead of a 45-minute scan, which they all think they're coming in for a 45-minute scan. But when I tell them, I'm like, oh, it'll be done in 20 minutes. They're like, really?
Yeah.
And I get them up. They're like, oh, wow, that didn't even seem like that. And I'm like, it's so much more comfortable. We have bigger bores now, so it's not nearly as small as it used to be. And it's a lot better for the patients.
Yeah.
MRIs are the ones that sometimes people say are claustrophobic, right?
Right.
Yes.
Yeah.
They say it's like going in a tunnel, and it is. And so, I've always joked, part of my job is kind of being a therapist. Like, you have to kind of walk them through it, talk them through the whole thing. And that can be anywhere from putting a washcloth over their eyes, giving them music, talking to them throughout the scan, letting them know, hey, you're not in there by yourself. I didn't leave.
Yeah.
But, it just takes a little bit of everything to kind of sometimes get those patients through those exams. And the shorter time frame really, really helps to get all the images that we need so the patient gets the exam and they can get the results they need.
Yeah, and I think we have the largest bore size of our MRIs that's being made without having to go to an open unit, which we really don't prefer. Closed units are they
More
produce better
accurate.
images.
Yeah, I know a lot of people. Was some hype around the open,
Right.
but now with the bore size being so much larger and that better image quality, it really is better if you can
It is.
get the full.
Our claustrophobic rate has gone down because of
Tremendously.
Yeah.
Like, I used to have, I'd say 1 to 2 a day maybe, or somebody that came in medicated, where they had taken something to help. And now it's 1 or 2 a week, if that. So, it's dropped tremendously, and it really, really makes a difference.
Yeah, that's good.
Yeah.
And that is an option if you are really claustrophobic. You could ask your doctor
Yes.
for a medicine to help
Yeah.
you with that,
Yes,
for
for
just that
sure.
procedure.
And then with the same advancements in MR, we've had it, within CT as well. In
What does CT stand for?
CAT scan.
CAT scan. Okay.
So,
I just forgot.
when I came in 20 plus years ago, a head could take 35 minutes just to scan a head. We're doing that in 2 minutes.
Oh my goodness.
So, yeah, there's been so much advancement. You started out with a 1 slice CT, then they went up to a 4, an 8, 16. So everybody was, trying to position themselves within the market to have the highest slice CT.
What does that
I
mean,
know, I
the
was gonna- the
slice?
So slice comes down to the detector size and the speed of scan and how fast it can acquire the images. Like the last one that we put in down in the ED, it's a 256 slice, which with the time that we put it in, there was only 4 that had been installed in the Southeast United States. But this gives us such an increase in speed of scan that we can actually scan the heart in motion without there being any artifact, any motion, any of that. So what we'll do is take the leads, we'll hook it up to the unit, we'll bring the patient in, and that unit will coordinate its scan in between the heartbeat. So fascinating equipment.
Yeah. And that's
Fascinating.
especially important in the ED when you need those
Very much
results
so.
Right.
quickly.
Yeah.
Yes, yeah. A lot of the newer equipment coming in has the ability to diagnose. It will run a QC program every 24 hours. If there's an issue, it will send into headquarters, hey, we have a detector issue, a cell may be going out. It'll go ahead and order it, and it will have it in process, and we'll also have something in queue for the engineers to know, hey, we need to be putting some attention on this equipment down here.
That's very interesting. I know that probably the biggest thing that you see if you go in the ER and you're taking a machine to a patient, like you do, where you take mobilize and go to the patient, they're looking at whoever's doing the test to give them some inkling of is something
Yes.
wrong.
Like, what did you say?
Can you tell me, am I
Yes.
okay, am I
All the
not?
time.
Yeah.
And I know that you can't really, do
No.
that at that point. So tell a little bit about that. What is the process once the image is taken and how that works?
It's difficult. It's very difficult, especially when you're starting out, because the staff don't want to say no. They
they
don't
don't
want to
wanna,
say,
like-
Yeah.
I don't see
And
anything.
they will
when,
try to bribe you for sure.
Yeah, they will. You just have to understand that, we're here to provide a service to assist the physician. And that's what it comes down to. We're here to take the image, not allowed to be able to give you the diagnosis. That's the physician's job, to give you the diagnosis and also what treatment's going to be provided. So we explain the process. We take the image. Once it's processed, we'll get it to the radiologist, and then the radiologist's interpretation will go to the physician. So it is one of the more difficult and frustrating parts of the job, because you do want to give them a little bit of relief. Because I've had patients grab my arm, please just tell me something.
Yeah.
I'm like
we know you know.
Yeah, exactly.
You can see
it. And, you know, the company where you're going to be fine.
Yeah.
You're going to be fine.
And about how long does it take to get the report back from the radiologist? Because I'm sure the time on that has also decreased with the advancements in technology as well.
It has. So it's twofold. So because of the speed of the equipment, where we can accommodate a higher volume of patients, that's also come to kind of a bottleneck with the physician.
Doesn't make more physicians.
Right.
Yeah.
So and one of the issues that is nationwide is the radiologist availability. So recruiting that's been very difficult. So what we've done is we brought in some AI components that will assist them. You know, 5 years ago there was an author, and I won't say his name, but he wrote a book predicting that AI was going to take over for the radiologist, and that there would be no need for them. And that possibly could have had a negative effect on these younger physicians going into the field saying, you know what,
I don't
think I want to go to
Yeah.
radiology because I'm not going to have a job. And that's not the case. AI is an assisting tool.
It helps, but even on my scanner, like we have some AI generated auto scan features, and you still have to perfect it. It's
Yeah.
nothing is
Yeah.
perfect.
Can't take away the human element.
Exactly.
Correct.
Yeah.
Absolutely.
It helps, but it's not.
Absolutely.
I don't want
It's not a
artificial.
guarantee.
Yeah.
The last thing you want is, as a patient, to come into a facility and all you're doing is interacting with a machine.
Yeah.
And, I mean, you see the frustration that you have when you just, you know, dealing with a call tree, trying to get a
Right.
human person to just answer a question. So the last thing a patient wants to do is just walk in and not have any human contact. So going back to the question as far as the radiologist, yes, their turnaround time is much quicker. And we have some AI tools with that. We also have brought in teleradiology, so that gives us some support as well. So if our radiologists who are on site are backed up, we just go ahead, we switch over to Telerad, and we bring in that assistance as well. So we have our benchmarks too for, you know, your stats, your traumas, your emergents, and those metrics look really, really good. And especially for those traumas and strokes.
And I'm sure you have to navigate, like you said, you have to almost triage the images per se for the emergent,
Right.
Hospitalized versus something that's not life-threatening.
Right.
Agree.
And then the next part of that is, okay, the radiologist reads your report or your scan, the report shows up in your MyChart, and then you're like, I don't know what this says.
Yes.
So you go straight to Google, of course, and like, what does this mean? Or ask ChatGPT or whatever. But why is it important for patients to wait and discuss those results with their primary care provider or whoever it was that ordered that
There's
test?
so much more that goes into getting a diagnosis, whether it be the imaging, the lab work, the symptoms, the physical exam, and people forget that it's medical, you know, healthcare is all conclusive, and it's not 100%. Nothing is. And so it takes all of those aspects of it to take care of people. And so I think that's kind of the biggest part of it is it takes everything.
That's just one piece.
Again,
Right.
you need that human element to break down that medical terminology so it's relatable. Because we get those phone calls that my report says this, and I need to be seeing somebody right now. And you know, the physicians are calling it with what it is, but it doesn't say, look, this isn't as bad as what it's perceived or what you think it is. So that's the biggest downside to getting the report and then going straight to Dr. Google and trying to get an explanation. Be patient, let the physician explain. And that's one thing that our patients need to understand is when you get that report, or even prior, if there's a negative finding that has a significant effect, a negative, you're going to get called.
Yeah.
They're
that's
gonna
the
tell you.
Those red
exactly.
flags, they go out.
These physicians do not want to let you be out there with something that could be life-threatening and you not get a hold of. And that's one thing that the patients don't see is the behind-the-scene work that our staff, our radiologists, our physicians are going through, just trying to get that patient either back in or say, hey, look, we need additional scans.
In those cases, no news is good news. That's
Yeah.
Exactly. That's what I tell people.
You're
You
not
know,
Yes.
when you're on a Friday
That's a fact.
afternoon, someone's having, this super stressful, scary scan, and I'm like, listen, if there is something critical, someone's going to get in touch with you.
Yeah.
They're not going to let you sit all weekend
Yeah.
thinking that it's all over. Promise they will get in touch with you.
I remember once I got an ultrasound for something else, and then the report said that there was some millimeter non-obstructive kidney stone. And I'm like, what? Have a
Yes.
kidney stone? And the doctor's like, it's really tiny. You don't even know. Unless you're having symptoms, you're fine. Like, oh, okay.
And that happens all the time.
Yeah.
Incidental findings are all the time.
This is why I stopped getting on the scans as a guinea pig when we were
Yes.
putting in
It opens a can of worms
I
for sure.
never
Yeah.
got off of the scan without them finding something. So I
And you
stopped.
could. And
I
that's
had
the
that
thing.
thought when they were doing the implementation for the new scan. They were looking
Yeah.
for people to
Yeah.
the scan. I'm like, oh, you might not want to look.
Yeah.
You don't know what you're
don't want to find something
One of
else.
the radiologists, he's like, I'm not getting on there. He was like, I know what happens. He says, nope, we're not doing it. We're not
Yeah.
starting that.
You very rarely could pull a person off the street and scan them and not
find
find an
something,
anomaly or some type of pathology in there. Yeah.
I never thought about y'all being the guinea pigs to test out the
Yeah.
machine.
Yeah.
I tell everybody when it
Collaborate on
comes to
it.
MRI, I'm like, it's kind of like, you have to go through it so that you know what your patient's going
That's
through.
right.
You know,
Exactly.
you have to know what it feels like so you can coach them through it.
That's a good point.
Yep.
Are there any myths that you hear all the time about imaging or tests, scans that you want to address?
You'll glow in the dark after enough X-rays.
okay.
Yeah.
Glow
Yeah,
in the
there's-
dark.
Yeah, there's a lot of fear on the radiation side of things. And we're taught this from day one. It's X-ray 101 is radiation safety. And what patients don't understand is that the radiation that we're administering is minimal. You're going to get more radiation in a day at the beach than you would through a chest X-ray or something like that. Now we do have some scans that are more invasive that require a higher dose of radiation, but that's where you start discussing what the cost versus benefit is there. And most of the time, life-threatening to the point, hey, I'm not worried about this radiation dose. And patients don't realize we have application or software in place. Each patient coming through, their radiation dose is recorded, so it goes in their file. And if there is any radiation that goes over the level that we have set, then we're to review it. We're to discuss it with the radiologist. But we've never had any that is to the point of a patient dose that's of any concern.
Yeah.
Most of the concern is for the staff.
Yeah, I was
Right.
just about to say, what
Correct.
kind of precautions do you
Yeah.
take as staff when you're the one that's exposed to it every day on
Yeah.
your job?
So we're in the dosimeter badges is what we have. We're allowed 5 millirem per year. I've been in the field for 20 plus years. I don't know anybody that has gotten that much. We practice the three. It is our 3 golden rules within radiation: time, distance, shielding. Time being the amount of time that you're on the foot pedal or on the rotor switch administering the radiation. Distance is backing away from the source of the radiation, and then shielding, of course, is using lead and shielding in front of you between the source. So we keep those. Everything is monitored. Everything is reviewed on a daily. I say daily. We do on some areas review these, but for the most part, we get our monthly reports. We go through them. And if there's any significant dose to one of our patients or employees, we get a report. So monitored. Very
all the
heavy.
little mechanisms that are put in place to keep people safe on the back end. It's stuff you never think about, but it is reassuring to know that you have that
Yes.
and that you are monitoring that.
Yeah.
What would you say? I know we don't have much more time, but for anyone looking to go into a career in imaging, any kind of advice or?
Possibilities are endless.
Yes.
You can start, and the good thing about Georgia is you can start in X-ray, get that foundation, and then there's opportunities in CT, cath lab, MR, and just so many other parts of the hospital that you never knew were an option until you kind of get in here and get into the nooks and crannies of the facility and see where all you can go. I mean, you might figure out that OR is where you want to be. You don't want to be a scrub tech, but you like working the C-arm. So there's so many different things that you can do with it. And you can
'cause
change it up
have
if you want
imaging
to.
in surgery, right?
Yes.
In the hybrid OR. I mean, you don't
Yeah.
typically think about having those big machines in there, but they are, and they use
Yes.
those. And
Yep.
so anything from the outpatient to the
And
inpatient.
how long do you have to go to school for that? Is it 2 years?
Yeah, so it's been reduced. I think it's down to 7 quarters right now.
okay.
That's after you have your prerequisites. So 7 quarters within the program that you're allowed to take the board. At that point, you're going to come in and begin your career within X-ray as we know it, plain film, and then we can then work with the staff as far as where their interests are in going into cross-training into another modality. But the advancement in pay in the last 20 years has just been phenomenal.
Yeah. And you will always have a job.
You do. You
Yes.
always
Anywhere.
have a job. And I mean, I'm a perfect example. I started out as a tech assistant going through school in a very short time was, before even graduating from school was doing the responsibilities of what a tech is, and then just worked my way up into administration. Started out as a supervisor, a chief, manager, and now director. So again, it's like Dee said, it's endless.
Yeah,
endless.
well, with our aging population, and then we're not really getting
Healthier.
healthier as a society.
We are
So
not.
the demand
Yep.
is
Yes.
there,
Definitely.
and we can only do so many images, but we've got to have the people that are
That's correct.
doing them.
Yes.
Because again, we don't have robots to do that. So
That is
we don't
correct.
want them. We want our people.
Well, thank y'all so much for joining
Thank
us
you for
today.
having us.
Thank you.
Yes, we really appreciate
Thank
it.
you for allowing us to promote imaging. Very
Yeah,
proud of it.
absolutely. All right. Well, thank y'all for tuning in. If you haven't already, please like and subscribe.